시청자 여러분 안녕하세요.
Dear viewers, greetings. This is Prosthodontics on Friday Night Live, which addresses different prosthodontic straps as well as its side effects. In 2023, the grand theme is Back to the Basic Full Denture. We're now heading towards the end of 2023. We have 3 lectures left. Today we have with us Dr. Park Hee-young of Seoul East Dental Clinic. We're going to talk about implant overdentures. Greetings. This is a third Prosthodontics on Friday Night Live lecture with you. I am very intrigued as to what you have prepared today. So the grand theme of the semester is full denture, and I'm going to talk about implant overdenture, which utilizes a few number of implants. I look forward to the lecture on overdenture. I feel intrigued. Those of you watching from dental site, you can participate real time using the chat, leave your questions, have them answered, and through a lucky draw, you'll be able to win Starbucks coffee coupons. Those of you selected as the best question will receive 3 Starbucks coupons at once. I look forward to your keen interest and participation. Let us begin Dr. Park Hee-young's lecture. Greetings, I'm Dr. Park Hee-young of Seoul East Dental Clinic. As Professor has mentioned, this is my 3rd time appearing in Prosthodontics on Friday. You're a stellar lecturer, that's why we've invited you 3 times. I am honored. I have a blast whenever I come here. I learn a lot. Today I have brought about 30 slides about implant overdenture. Implant overdenture is an excellent alternative restoration that can address the lack of stability and retention that the conventional full denture has. It can improve the patient's quality of life significantly. I have tried these formats and restorations in multiple patients. As shown in this case, the patient has been using this for over 15 years without major problems. Sometimes patients have great prognosis, others have some difficulties. The most important consensus report on implant overdenture was introduced in 2002 with the McGill Consensus Conference. After providing 2 implants in the lower, if you provide implant overdenture, you can improve the quality of the life of the patient. This can be first choice for fully dentulous patients. I think that these contents are still valid today. And using this criteria, I provide implant overdenture restorations. Let's talk about the lower first. In providing implant overdenture in the lower, my preference is to utilize solitary attachments. I do not utilize bar attachments frequently these days. It's comparatively more complicated, and in terms of cost and efficiency, there's not major plus against solitary type. Let me show you a typical case. The patient is partially dentulous, and the patient was wearing partial denture in the upper and lower. The patient was female in 60s. You can see on the x-ray the mobility level of residual teeth were about 2 to 3, and they all required extraction. We need to determine the timing of extraction nicely. The reason being, we need to minimize the patient being fully edentulous or partially edentulous. 2 remaining teeth in the lower were extracted and existing denture was adjusted, and after 10 days, attachments were connected. Early loading was done for the implant overdenture in the lower. 2 locator attachments were used. The existing denture was transitioned into temporary denture to minimize patient being edentulous. The residual teeth in the upper were extracted. Immediate denture was fabricated. The existing denture the patient had was transitioned into new immediate denture, and locator attachments were used to minimize discomfort on the part of the patient. The implant overdenture fabrication process is almost exactly the same as fabricating full denture. You take preliminary impression, final impression, and you check jaw relation. On the cast, you make wax denture and then do try-in. Attachment socket connection is done using a resin in a direct method after final denture is complete. Final denture was provided. After delivery, through the course of multiple times, you need to make adjustments. The patient never returned despite repeated calls, and after 7 years, the patient came back. You can see the hazy part of marginal bone. There is gingival recession as well. The attachments were intact. The socket of locator attachments were not replaced once for the course of 7 years, but there was still retention. The prognosis was excellent. In principle, you need to replace the attachment socket every 6 months or once a year. I've talked about the overall treatment flow. There are a couple of notable attachments used in implant overdenture. First is a ball attachment. Ball attachment has been used very long. It's simple and it costs less, and it's compatible with different manufacturers. It's easy for maintenance, however, it has less retention and it lacks durability. There's standard diameter ball and a mini diameter ball. This is the image of a ball attachment denture connected to one body restoration. The patient had the original denture and we placed 2 additional implants to supplement it. The patient has been using it for 10 years without major problems. The frequency of ball attachment usage has gone down for me. I use locator attachment primarily. I use magnet attachment at times, but there are many discomforts clinically and in terms of usage, and from patient perspective, it can be quite frustrating because there's lack of retention. Also, when attaching the magnet, you need to do it precisely following the axis. It has lack of retention, but for the upper, it can be an advantage. You can use magnet intentionally to prevent lateral force, and once lateral force is applied, it becomes dislodged. So in a sense, it protects the implant itself. This can be considered a plus. Among the solitary attachments, this is the most frequently used one locally. This is locator attachment. The gingival height ranges from 1 to 5 millimeters. And there are differing sockets that have different retention. The attachments, such as locator attachments, have advantages in that it can be used when the vertical dimension is low and it has strong retention. And the retention socket can be replaced 6 months to perhaps a few years. It has compatibility with different components, and it can be used for different implants. The downside is that because retention is too strong, the patient at times have difficulty removing it, and overload can be applied to the implant because of it. If abutment wear occurs, you need to replace the abutment itself every 3 years or 5 to 6 years. The patent for locator attachment expired a couple of years ago, and there are now many compatible products available. Awesome port attachment also has the same dimensions. What is interesting is that the gingival height options range from 1 to 7 millimeters. If the implant has been placed deep or if gingival tissue is thick, it can be very useful. There's angled products available, so prosthodontic options have become more varied. It's a major plus. And it is more compatible with Ostem's abutment and implant. This is a case done by Professor Joino at Twin Dental Clinic. 4 implants have been placed in the aesthetic zone, and overdenture was provided. Being able to respond to different gingival colors can be very beneficial. Placing 4 implants here. In the case of port attachment and locator attachment, at times it can be quite difficult to remove it because the retention is quite significant. At times, patients find this difficult, but with time, things improve. In the upper, it is difficult to place the implants completely parallel, and there can be angle deviations. That can be difficult as well. Also, there are angled options. Next, I want to talk about bar overdenture. So, over 2 implants are connected using casted bar or stock bar. Before solitary attachments were available, bar attachments were used as standard. When you provide bar overdenture, vertical space is necessary significantly, as shown here on the image. There needs to be at least 13 or 14 millimeters to secure appropriate component thickness. It is possible to provide such restoration even if there's less, but metal frame or denture base can become thinner and continuous fracture can occur. We need to make sure that there is sufficient vertical dimension. At times, I attempted bar overdenture in the upper. If you look at the patient, it is 82-year-old female patient. At my dental clinic, my patients are primarily elderly. The patient originally had 2 implants placed, and implant overdenture restoration was provided. And in 1 implant, the platform fracture occurred. The implant was removed. 2 implants were added in the canine region. Transfer impression and soft tissue impression was taken. Bar and denture were fabricated. The fabrication process of bar attachment is much more complicated than what you see on the screen. In the denture base, there needs to be sufficient thickness and it needs to be buried there. Tentative jaw relation is taken before fabricating bar and teeth alignment is done. You check the thickness of teeth, metal frame, and denture base and then fabricate bar. You merge the 2 scanned data and you check the thickness using CAD/CAM abutment and hater bar structure. Hater bar is attached using RMGI cement in the custom abutment, and the clip is made vertical to the midline. Denture is not complete at this stage. For final denture fabrication, jaw relation and wax rim is checked once again. It's the same model. Intraorally, abutment and bar are connected. Wax denture try-in is done. After that, you do curing in final denture position. I've tried to summarize it in one image, and it's really complicated, so I get confused sometimes. I'm sure you have a lot of experience providing bar overdenture restorations. In 90s, when I was at UCLA Implant Center, bar overdentures were provided as standard. There were many lab process involved, and there were many limitations. There needs to be sufficient space, and at times you use only one, but at times you use 2 or 3 heater bars. If the path is not right, it can get crumpled, and it may not fit properly. Compared with when we use locator or O-ring, it will become more complicated and there will be more limitations. Based on my experience, I tend to avoid bar overdenture because it's more difficult. The follow-up period is not significant, but despite many risk factors, but because the patient was elderly with weak masticatory force, and because the patient took care, up until now things are fine. We're doing follow-up. Can I ask you a question? Based on my clinical experience in the lower, we placed 2 implants and the patient could use it fine for a long time. But in the case of the upper, if you provide just 2 implants and do overdenture restoration, sometimes failure can occur. Dr. Park, when you place 2 implants and provide overdenture, unlike the lower, there's frequent failures. Why do you think the reason is so? In the case of lower, you can get good success rate with that. What's your opinion? In this case, 2 bar were connected. It has splinting effect. I did not use bar in the upper and I used 2 solitary attachments. In that case, you can get very good prognosis. In most cases, there can be peri-implantitis or there can be dislodgement of the implant itself. The retention of attachment socket can be lost extremely quickly. When I looked at several literature, implant overdenture using solitary attachments in the upper, because overdenture has a lot of bone loss, prognosis is known to be not so good, and it says that it cannot be recommended as general treatment option. And my experiences are in line with that. Compare with the lower, the upper has the limited bone quality and bone quantity. In terms of epidemiological aspect, in the incisal surface, a torque occurs significantly. It's also unfavorable because the placement position is towards the palatal side. Epidemiologically and biologically, there's a fundamental limitation in the upper, and the implant overdenture cannot inherently serve a good role there. When I provide restorations for the upper, I choose 4 implants rather than 2. And the conditions are more unfavorable in the upper. I think it's ironic, but as you have mentioned, for full denture, it's very difficult to do for the lower, but with the dawn of implant period, the upper has become more difficult. It also rings true for the fixed prosthesis. As for conventional denture, people find the upper more easy and retention and everything is all good. But when you provide the implant overdenture, at times it can be a problem. That is why the McGill consensus report is all the more meaningful. The recommendation is to place 2 implants for the lower and conventional full denture for the upper. I try not to get swayed even when the patient wants implants for the upper. You need to draw a line at some point. When you think of the finances, we may need to place implants, but there are many difficulties.
예, 그렇긴 한데 그 뒷일을 생각하면은 좀 어려운 문제가 있는 것 같습니다.
I'll continue on with my presentation. Wait 1 second, please. Doctor, there are many words of encouragement here. Let's take a brief look. Perong, Prosthodontics on Friday Night Live is the best. 찰랑찰랑. I look forward to the program Professor Jo In-ho and Dr. Park Pyoung. Arirang, I look forward to your lecture, Dr. Park. Smart Dental Life, Dr. Park, I look forward to your Overdenture lecture. Dr. Park is really famous. I think a lot of people are looking forward. 도둠체, I look forward to today's program. 심쿵두쿵, I always enjoy prosthodontics on Friday. Bold Moon, greetings, I'm a dentist from Mongolia. I always enjoy this program. A dentist from Mongolia to listen in on your lecture, Dr. Park. It's off topic, but I had my summer vacation in Mongolia and it was really memorable. The plains are awesome, yes. Wehas, the tooth doll is absolutely darling, and you're really cute too, Dr. Park. I brought it, so I will be able to gift it to you. It does not just stand still, it moves around. When you're bored, you can twist it like this. And this is my gift to you, thank you. I hope the overdenture, which is the topic of the day, serves its function just like this toy. 금요금요, I hope it's Friday every day. The toy is absolutely cute, just like you. Thank you for the wonderful lectures. Thank you for the words of encouragement. I would like to gift the dentist from Mongolia, but I don't think we'd be able to send the Starbucks coffee coupon to Mongolia. If you were here in Korea, we would have sent it, but this is impossible. I would like to select the Kumyo who has said that I hope it's Friday every day and that the toy is absolutely cute, just like the professors. If we could send one Starbucks coffee coupon to this person, it would be deeply appreciated. We have received so many words of encouragement from so many people. I would like to express my gratitude to all, including Kumyo. And as MC, I would like to send Starbucks coffee coupon to ID Kumyo. I look forward to your continued interest, and I hope you raise many questions on the real chat. After Dr. Park's lecture, Q&A session will be held to address your questions. Dr. Park, please carry on with your lecture. Up until now, I've talked about many positives of implant overdenture. But on the downside, there are many factors that make dentists suffer. Many patients have high expectations when they receive full denture implant overdenture. They hope that it won't hurt at all and that the denture would stick in its place and will be able to chew everything. They have excessive expectations. I try to lower such expectations when I come across these patients. Implant overdenture is removable denture. It has problems that exist with conventional full denture. There can also be mechanical complications related to attachments. Rather than complication, this can be viewed as maintenance issue with long-term use. Attachments and other components can be mechanically damaged or wear can occur, so you need to replace them regularly. Every now and then, the socket that is attached is dislodged from denture base, and at times it is stuck to the attachment. Yes, that happens. At first, you might think it's gone, but in some cases, you'll be able to find it in the attachment. So you attach it again. I've used a Duralay pattern resin. It's fine, but at times when the denture base is thin, it can show through and it may look as if there is a fluid retention. If necessary, I use pink resin or the Kuzuru base. I believe there are other great options available. I think it stays nicely if you use resin cement as well. Among mechanical complications, abutment wear can occur. In the case of ball type, wear occurs. As for locator type, retentive undercut wear can occur after 3 to 5 years. Patient may not be aware that the plastic socket has fallen off, or wear can occur with continued contact with plastic here. When retention does not improve, even with socket replacement, because of wear, you may have to replace the abutment itself. Unlike fixed prosthesis, you have to regularly replace abutment, and this is something that you need to have the patient understand upon consultation. Next, compared with conventional denture, because masticatory force is stronger, there can be denture base or metal frame fracture, and such tendency increases with time. In the beginning, the patient may have been more careful, but because the patient does not feel pain, unconsciously the patient may have started to chew more strongly. Fatigue fracture may have occurred as well. When I do implant overdenture in the lower, the metal frame is made about half above the socket to reinforce it. The lower anterior area should be metal frame because it's quite thin. I've talked about McGill consensus report and how full denture should be provided for the upper. If there is residual dentition in the upper or in the anterior zone, there can be a lot of mechanical complications for implant overdenture in the lower. Gingiva can be an issue around the implant. There is support, but towards the posterior side, where there's a lot of bone loss, sore spots or inflammations can occur. The patients have high expectations of implant overdenture, and they think that it's going to be painless, but they can feel disappointed once they get the actual prosthesis. We need to help the patient understand. We also need to make extension and the fit with mucosa and occlusion the same as full denture. Around the attachment, there can be hyperplasia. At times, we can do excision or address the inflammation to reduce the swelling. By doing this, the patient will be able to use the denture well. Based on my experience, when implant overdenture is done compared to fixed prosthesis, more gingival recession occurs around the abutment and its surroundings. It's just my assumption, but as the denture base of removable denture continues to stimulate the surrounding mucosa compared with fixed prosthesis, more recession occurs. When implant overdenture is provided, compared with fixed prosthesis, you need to place the implant more lingually and prepare for recession. Gingival color should be at least 4 to 5 millimeters. This is a literature about the bone loss in the posterior area when implant overdenture is provided. 11 years after prosthesis delivery in the molar area, there's no implant that can provide support. Hence, over 2 millimeters of alveolar bone loss was observed. It clearly shows the limitations of the masticatory force in the posterior side when implant overdenture is provided. Implant overdenture is a good treatment option for edentulous patients, but I always tell my patient that by adding 2 implants on both sides of the posterior area, we can transition the prosthesis into fixed type anytime. By using 2 additional implants, we can transition the prosthesis into fixed prosthesis, and we can dramatically improve the masticatory force once again.
드라마틱한 그런 저장력의 개선이 일어나는 것 같습니다.
This is the last bit to summarize. Implant overdenture can be applied where the bone is, but you need to make a strategic decision and you need to place it in the canine area and in the center of the tooth. You need to tell the patient of the advantages and disadvantages of implant overdenture repeatedly. Implant serves a supplementary role, but we need to focus on the functions of full denture, and implant is just a supplementary. By doing this, we can maximize the usefulness of implant overdenture. Because it is removable prosthesis, it is essential that regular maintenance be provided.
일정 의치인 관계로 또한 메인테너ンス 또한 주기적으로 하는 것이 꼭 필요할 것 같습니다. 그래서 제가 이렇게
This is what I've prepared today. Thank you for providing a wonderful lecture in a very simple and interesting manner.
대단히 감사합니다. 예,
Dr. Park, let's look at the
저기
chat screen in the dental site.
오늘 다시 한번 확인해
I'm sure there are a lot of questions.
질문이 올라와 있을 거라고 생각합니다. 그러니까 오늘
There are many questions that are off topic today. Unfortunately, these questions will not be answered.
내용과 관련된 것에
We'll focus on questions that is relevant.
답변해 주시면 대단히 감사하겠습니다. 바쁜데
Let's take a look at the questions.
쭉 한번 보겠습니다. 이건 아니고.
Kyonu, in the case of lower, for locators, how many of them should I use? Basically, I just use 2.
기본적으로
The more the better, but
물론 이제
and if you use about 4, you'll be able to get support in the posterior area as well.
또 지지를 얻을 수가 있어서
지지가 있어요.
But compared with the effort and cost that's put in, you cannot really look forward to dramatic effect.
얻기는 어려운 것 같습니다.
Prosthesis is difficult to deliver in the posterior area, and the surgery can be difficult. Maintenance can be difficult as well. When placing implant in the molar area, masticatory force can be quite significant. There can be damages to attachment and there can be loss of socket. There also can be fracture of denture.
두 개만 해서 환자의
So I just use 2
걸리지는 않게 그 제한을 해서
and I make sure that
자동차도
the masticatory force does not increase, like limiting car speed. If the patient chews too strong, I make sure that the patient feels a bit of pain. By doing this, you can protect the tissue. Doctor Guide. In the center of port abutment, there is 1.2 hex holes, so it's very easy to tighten and adapt.
그게 생겨가지고 조일 때 이제
I'm sure this person knows very well about the port abutment. I didn't realize
원래는 삼각
because it's originally shaped like triangle and it was difficult to find the right axis.
헥사 홀이 있으면
If there's hex hole, I think it'll be very easy to use. Can do. In the case of upper, prognosis is not very good if you use overdenture. In the case of upper, how can I improve the prognosis? What kind of overdenture can I provide? Dr. Park, you have mentioned a conventional denture. If we are to place implants, would you place the 4 rather than 2? Yes, it's very vague. You need to consider the cost and period. Placing 4 implants and providing solitary attachments, I do not have experience of that. To have enough bone quality and quantity to be able to place 4 implants in edentulous cases is very rare. If I were to do it in the upper as mentioned, I may use magnet attachment. You would use magnet to prevent lateral pressure. You can also get the splinting effect by using locator. In your case, I've talked about it. I'm unsure as to which is better. Implant overdenture in the upper is not a contraindication. I feel very cautious about it. If you can get good retention with conventional denture, then you can use conventional full denture. If the patient has severe gag reflex and if the denture base cannot be extended towards the posterior area, if you are to do open palate denture, then you can place 4 implants to get retention in the posterior area. That is my opinion. There's another option. You can place 3 to 4 implants in the anterior and connect it in a bridge type, and you can utilize IARPD. There's a splinting effect. These days, IARPD is more common. When I first placed implants, people said that clasp should not be utilized. That's why in the past, partial denture was not attempted. These days, we try partial denture in different designs and it can be very successful. Placing 3 to 4 implants and attempting IARPD can also be a good option, especially in the case of those above 65. 2 implants can be insured. When there are root remnants, for fully edentulous cases, this is not insured. We can place implants, and partial denture can be insured as well. You can utilize that option. IMD in the lower, when we place 2 implants and do implant overdenture, can I attempt a narrow diameter implant as well? You have shown long-term success with the case using mini implant. Is there a need to place regular diameter implant? It's an excellent question. In my case, that was a well-done case. It was a very fortunate case, mini implant, to give you a conclusion. There are many uncertainties for it to be used as a final prosthesis because the diameter is thin. There can be implant fractures. The ball on top is smaller. The neck part of the ball can be fractured as well. If it fractures, then it's impossible to remove. The buccolingual bone is too thin to be able to use trapfine burr. Then you just bury it and place implant nearby and provide restoration. Many difficult problems can arise in this situation. If you are to use mini implant, you can use it for long provisionals. You can use it for 3 to 5 years. I think there are many uncertainties and question marks for it to be used as final restoration. This is not a contraindication. In the case of full denture cases, it may be a little bit okay considering antagonistic condition, and if the age of the patient is over 70s or 80s, then we can utilize it with caution. Kyonu, without doing full coverage in the upper, and If you do U-shape open palate, how many implants does it require? I don't frequently do U-shaped open palate design. I form posterior palatal seal and I extend the flange towards the tuberosity. In order to make it U-shape, you need to have at least 5 or 6 to be safe. 4 at minimum, and it needs to be symmetrical on the left and right, so it needs to be about 6. But with 6 implants, you can provide fixed bridge as well, depending on the condition of the lower. Bar overdenture in the upper, it's a difficult question. If you look at the literature from the Western world, there are different restoration designs for fully dentulous cases, but in Korea, our eating habits and our diet is much more tough. We like radish kimchi and we chew on crab shells. So I refer to this as K-occlusion. We often see patients with fracture restorations after having chewed on something hard like crab shells. Also, we need to fabricate with a significant safety margin. More so than what is reported on the literature. Nice to meet you. I use locator attachments for overdenture in terms of maintenance these days. I place 2 to 4 implants and make a bridge in the anterior area and consider partial denture in the posterior area. So this is what we've talked about just now. I think this is an excellent method. Kyonu, is teeth alignment difficult when you make bar metal housing on denture? Metal housing on denture. By teeth arrangement, I think the person is talking about how the space is limited. I've shown you upper bar overdenture case. We need to make significant considerations on the thickness of denture base, metal housing, and artificial teeth. The bar alignment needs to be done in line. An experienced lab technician needs to pay a lot of attention to it, and the dentist needs to be fully aware of the process, so it's very difficult if the bar sticks out of the denture base and made inappropriate. All problems start to arise. Awesome. Welcome, bold mood. This person is welcoming the Mongolian dentist, Kyonu. In order to prevent gingival overgrowth below the bar and to do healthy gingival management, how much distance should there be between bar and gingiva? I think it to the point where pressure is not applied. I think this person is talking about bar overdenture. If it is too close to gingiva, hyperplasia can be observed. By providing more distance and space, perhaps we can prevent that. To be able to do that, interarch distance should be secured. I think there needs to be at least 2 millimeters of distance between gingiva and bar to prevent the gingival overgrowth. If it is too close, there can be gingival overgrowth or hyperplasia. If there is a certain amount of distance, we can prevent that problem. I think there needs to be at least 2 millimeters of distance. I agree. I think it can also be affected by the negative pressure upon insertion and removal as it is pressed. Fallen leaf. If the patient has full denture in the upper and overdenture in the lower, Are there any concerns of combination syndrome? In direct method, when should I attach denture socket, and when and how should I do relining for overdentures? I think this is a combination of 3 questions. Combination syndrome first. I've looked at several literature talking about combination syndrome. When you place 2 implants in the lower, compared with the upper, the occlusal force becomes significantly strong. You can provide strong occlusal force in the anterior area. There is no clear concrete evidence. There's a possibility that the patient already had combination syndrome. The residual teeth in the lower anterior, and the patient was using full denture. After implant overdenture provision, the situation may have worsened. As for class 1 RPD in the lower, there is danger of the lower teeth extruding or moving. Implant overdenture is buried under the denture, so it does not move together. Compared with the conventional combination syndrome, I don't think it's going to be expressed significantly. When we provide a distance in the anterior side, then the force can be reduced. The frequency of natural teeth causing combination syndrome is far less, and you don't need to worry about it. I agree. When should the attachment be attached to the denture socket? I use direct method. Based on my understanding, about 1 or 2 weeks, so without attachment to the attachment socket, you have the prosthesis serve as the conventional denture, and you look at occlusion and the fit, as well as extension. After you review all of these, you directly bond the socket intraorally. First, you have the patient adapt to the denture without attachments. This will lead to increased patient visits, and it can be cumbersome, but if the denture fit is not that bad, you can also connect it on the day of denture delivery. The time period is not an issue, and if you connect the socket on the day of denture delivery, in the case of denture that does not fit well, because the implant is fixed, it can mask the problem, so you will not be able to discern where the problematic area is. When you attach attachments in the denture socket using direct method, it may be more so when the implants are 4. In order to reduce time, at times you do it together. If you do it all at once, if things turn out good, that's great, but when you do 2 all at once, and if the fit is not ideal, then it can lead to many problems. Do you have experiences suffering because you have done it all at once? I have about 2 experiences. It was a nightmare. I had to remove the denture, and there's risk of implant falling off if the resin flows under the bar. If it gets stuck on both sides, then it can be a real problem. You need to rip everything out and start from scratch. When you attach using direct method, it's really nerve-wracking. You have to do 1 by 1. You should not do multiple all at once. When you use direct attachment method, you need to make sure you don't use resin too much from the beginning. At first, the pickup may not be possible, but it's okay, you can try it again. In my case, I use a brush. If the amount is lacking, defect appears. You then can use your brush to fill the direct resin in it. Another question is about when to do overdenture relining. Be it the direct or indirect method, when should you do relining? This is a quite difficult question. Honestly speaking, I've never done relining on implant overdenture because when you do relining, the denture turns into a completely new denture. Support area and occlusion, inner surface, border changes. It becomes a new denture. If you think about the purpose of relining, it is to provide a better fit for the patient. If the patient has been using the denture without a problem, but if you do relining to it, it's the same as having the patient adapt to a new denture. So I feel quite hesitant about doing it. If there is significant alveolar bone resorption and if the fit of denture base is reduced, I may do it, but otherwise, I just have the patient use it continuously. With long term, you may have to do it. When you do relining, based on my understanding, you have to remove attachment socket and then do relining. After that, you need to attach it again. I have a lot of concerns about relining as well. So I avoid the area with attachment. Even if I use a direct method, I go to other areas prior to the area with attachment can do. In the case of upper, if you use bar and magnetic overdenture using 4 implants, I've seen it last long term. Do you have a pattern that you recommend for the upper? In the case of upper, patients sometimes don't like the ceiling of the mouth covered, and at times implant overdenture can be recommended. You can use open palate denture. If you're going to do that, you need to place 4 to 6 implants. Using magnet can lead to better long-term result. Perhaps because lateral force is not applied, it lasts longer. But the retention is not good as the locator. I really find the doll funny. I want to buy that doll. Where do you buy it? You can buy it from a Chinese internet mall, starting with Ali. Gold Moon, I'll be able to use it when I go to Korea soon if I get Starbucks coffee coupons. So can we send Starbucks coupon to the person from Mongolia? Watanabe? I think this person is from Japan. Between locator and ball attachment, which do you prefer when providing overdenture? I prefer locator. This is used more frequently these days. A ball attachment is not bad, but I prefer locator attachment. Can do. With use, there is need to do relining for overdenture as well. I provided overdenture with 2 locators in the lower, and the patient says that there's a rickety feel. I think there may be bone resorption in the lower posterior. In the case of relining, when doing it in a direct method, is there a tip or precaution that I should take? Dr. Park has earlier mentioned that he does not really have a lot of experience doing relining, and neither do I. When doing relining in a direct method, you need to be very careful. At times, resin can flow into the area with attachment and it may not come off. Also, there can be other side effects. In the area with attachment, we need to make sure the resin does not go in. You need to do the other areas first, and with caution, you need to do relining in the said area. Indirect method could be better. After doing indirect method, you have to repeat the same process you have provided upon denture delivery. You need to look at the inner surface, PIP, and occlusal adjustments. Yes, you may be able to reduce a significant chairside work, but upon delivery, there can be many things to consider. 견우. Implant denture is about making a good denture, and the implant serves as a supplementary role for the denture. I find the fabrication of denture quite difficult. I agree. Yes, it's very difficult. Dr. Guide, upon connecting housing to the denture, do you have the patient bite on it or do you hold it? I have the patient bite on it, and there are considerations to make. Some people question how strong should the patient bite down on it. I think the patient can just lightly bite on it. The same for me too. If the patient bites down hard, there can be other problems. Pressure can be applied to mucosa and then fixation can be done. Continuous pressure can be applied. Also, there's the issue of rebounding. In general, you have the patient bite on it at times. The surgeon can adjust the force and hold on to it. After that, you need to do a occlusal check. Awesome. Do you connect the metal housing on the day of delivery? This has already been addressed. If the denture fits well, it can be done on the same day. Fallen leaf. If it is difficult to place implant in the lower canine area, where else can I place it upon immediate loading? How much fixation should I get? Canine is the preferred location. If it is difficult, which do you prefer, lateral incisor or premolar? I think lateral incisor is better because the rotational axis should be towards the anterior side. If you utilize premolar area, there can be seesaw effect. Up to number 4, it can be okay. I prefer lateral incisor over premolar. The zigzag effect does not occur much. If you place 2 implants in the lateral incisor position, then the movement that goes left and right can occur. Rather than clear lateral incisor area, you need to place it slightly more towards the canine. If the bone condition in the canine is not good, then we can look at the bone condition of lateral incisor in number 4, and we can place the implant where the bone condition is good. Can do. In the case of lower overdenture, where do you place the implant? Do you place it in number 3 to convert it later? In the case of anterior zone, labial version of insertion path is frequently observed. The denture's insertion path seems more vertical. For implant placement, what should be the insertion path be like? In the lower, as mentioned, the canine area is most favorable. In order to convert it later for fixed prosthesis, you need to accurately place it in number 3. As for lower anterior, implants are placed in a labial version position. As for denture, it is vertical to occlusal plane. The angle difference is not significant. We need to place it vertically following the denture position, and if you are to convert it to fixed prosthesis, if you use custom abutment, then there will be no major issues. It can be more labially inclined, but it's okay. 1. What is the criteria for immediate loading in overdenture in terms of primary stability and ISQ? Do you have experience doing immediate loading? You've talked about a week of term. I've done it in a couple of cases. Rather unexpected, but failures were very few. I've done it when the conditions were favorable in lower, such as a good bone width. I do not measure ISQ frequently. Primary stability. The implant should be in balanced contact with bone. Bone quality should be uniform and it should be over D2, and primary stability should be over 50 Newton centimeters. I was a little bit surprised because by 50 I thought you were talking about ISQ numbers, but that's not it. The denture should be stable, and even without implant, it should be stable. In that case, you can do immediate loading. In such cases, it can function quite nicely. Based on my experience, in order to do immediate loading, in terms of ISQ value, it should be over 75. Awesome. Are the specifications of the screws for commercially available retentive abutments interchangeable? Abutment screw. Mostly they are. It is better to use the same manufacturer's products. Understood, Kyonu? Which do you think is more favorable, placing implants in the canine position for overdenture or creating a bridge with canine as an abutment for removable partial denture? Placing only 2 implants in the canine region. I think this person is talking about lower. So you need to place over 3 in the case of upper. All things apart, I think it would be most ideal if Class 1 RPD along with 3-unit bridge in the anterior zone could be provided. From patient's perspective, even without the denture, VD could be maintained and it can support aesthetics. The patient would be able to be more pleased aesthetically. Can do. In the case of overdenture using bar, is relining necessary? Do you prefer indirect method over direct method? I'd rather you not do it. Now we're going over time. Awesome. Attachment overdenture is not insured, so the patient consent rate is not that high. So how do you talk with patients? Yes. Implant insurance. Now people can get 2 implants insured. The number of patients wanting implant overdenture has decreased significantly. They want IARPD or fixed prosthesis. Implant overdenture single attachment or overdenture using bar. I do not have a lot of these cases. I think this is the overall tendency. Implant. As of late, I rarely see overdenture using magnets on natural teeth. Is this because there is lack of clinical efficacy, or is this to do implant overdenture? I've only done it when I was a resident, and after I opened my practice, I've hardly done it. Adding attachments to natural root can have many limitations due to undercut, root caries, or other retentive issues. Adding overdenture on natural teeth using magnet, it does not last as long as implant prosthesis. I don't think it lasts over 5 years. Not just using magnets. I think people use other options less frequently. So how do you provide a space upon inner surface repair for overdenture? Adjusting the inner surface of overdenture, is this person talking about when it is bonded? I don't understand. I am unsure whether this person is asking about the space where the socket goes in upon attachment, bonding, or upon relining. We'll have to ask this person separately and reach out. I have a question. In the case of magnetic, it's very difficult to repair because the space is tight. As for magnet, if there's a distance, the strength goes down significantly, and I resonate with you. You need to be careful when you do it. Why do we, if there's only molar on both sides left, if I place implants and add attachments, can I provide partial overdenture without the posterior clasp? So the patient has posterior teeth left, then would it be okay to place implants and add attachments like a partial denture? This would not be impossible. I think it should have clasp for horizontal stabilization. IARPD or ISRPD. They should have all components of RPD. Because we're running short on time, as for the rest of the questions, actually, There's only a couple of questions left, so let's go through them briefly. Hut, home number, the most appropriate area to place implant in the lower is the canine area, because if you place them too close, the denture will be tilted left and right, and if the distance is significant, there can be anteroposterior tilting. Awesome. Upon connecting housing, do you use the black ring for lab work? Yes. You have to use it. After that, you need to change it. You need to block out the undercut using silicone or flowable, flexible resin. You need to polymerize it and block it out. Prost, positioning locator in the anterior zone and using healing abutment in the molar area for support. Do you use this? And is there a know-how to get the right to fit between healing abutment and inner surface of denture? Implant over denture. You can just place 2 implants. I have never placed 4 implants for posterior support. If I were to do it, after curing, you have to use direct method to adjust the fit between healing abutment and inner surface. Direct resin should be done. I believe we have exhausted all the questions. We received a whole lot of questions and it took some time, but thank you, Dr. Park, for providing such wonderful answers. Thank you, everyone, for participating on the chat. Now, let us choose the best question of the day. Those of you selected will receive 3 Starbucks coffee coupons. Dr. Park Hyun, can you choose the best question raiser? Before, a person raised 3 questions. The person who raised 3 questions. I think this is can do. Very important questions were raised. So I would like to choose this person. Thank you. ID can do. Congratulations on being the lucky winner. On Monday, we're going to send 3 Starbucks coffee coupons via text. Those of you not selected, don't feel too let down. We're going to select 7 people to send coffee coupons among those who have participated in the chat. Could you give a word of advice to your peers who have stayed up with us late listening in to the lecture on overdenture? I think I have deep ties with Austin. When I wake up, I use Austin's spoon to eat. I brush my teeth using Austin toothbrush and toothpaste. I place Austin implants using Austin chair. You're an avid user. Today, I'm providing a lecture at Austin. I'm leading in Austin Life. Thank you for using Austin. Perhaps Austin Pharma can produce shampoo and lotion as well, along with the toothpaste. That's a great idea. I will raise the opinion to the management. Implant over denture. As mentioned before, if you have high expectations, then you'll feel let down and so will the patient. Because it has clear limitations of removable prosthesis, so we need to be aware of that. We need to make sure that it functions as a denture. But I believe that we need to adjust the expectations of the patient as well as ours. Adjusting patient expectations. Thank you for wonderful advice. Thank you for coming here 3 times despite your busy schedule. Dear viewers of PROSTHODONTICS on Friday, did you like the lecture with Dr. Park Hyun? We were able to get clinical know-how of implant overdenture. We were able to answer all the questions today, but if you have further questions, we will reply them separately. In the next lecture, Dr. Oh Seung-hwan of Oh Seung-hwan Healing Dental Clinic is going to talk under the title All on X.
원장님과 함께 찾아뵙도록 하겠습니다.
Thank you once again for staying up with us up until late.